Bismillahirrahmanirrahim. This is the session of medical education, and we are discussing the medical education different models from apprenticeship to the competency-based medical education. Now, in the past, the model used for the medical education was the apprenticeship model. Basically, this was the model of ustadi and shagirdi. जो उस्ताद करता था, शागिर्द वही करता था. And I think around 2 centuries this model remain in practice. Halstead also used the same model, and in this model the master was the main person, the teacher. He used to direct, he used to demonstrate, comment and inspire. And Shagird, the apprentice, he used to listen, watches, imitates, does and seek the approval. And there were many problems in this apprenticeship model, which with the passage of time we felt is the variation of training, and whether we are addressing all the competencies which relates to the cognitive domain, psychomotor skill, effects, professionalism and ethical practices. So the word shifted from apprenticeship to the process-based and product-based model, and then finally they felt the model which should be in practice is the outcome-based and competency-based model. That is now in practice in the Western world and in Pakistan too. There they feel the students may forget what you say, but they will never forget what you have made them feel. So we define the competency as the identifying the ability of the provider to administer the safe and reliable care on the consistent basis. And competency-based medical education basically is the outcome-based. You set the competencies and then you match your instructional strategies, your training framework, your monitoring system and your evaluation system. And still we feel we have not been able to implement the competency-based medical education in true letter and spirit. And the first country which implemented the competency-based medical education was Canada, with the name of CanMed. Then you had the ACGME competencies, and then the Dundee's outcome model. And in Canada, they said the medical expert, beside having the expertise in his own field, should be a good manager, health advocate, scholars, communicator, collaborator, and a true professional. This is the CanMed model and ACGME competency. And at the level of Pakistan, College of Physician Surgeon, the main postgraduate body of the country, they feel the patient care should revolve around the research, teamwork, communication skill, knowledge, technical thinking, advocacy, professionalism and pedagogy. There was a system of integration of training, clinical research and the service to the patient. And during the implementation of this competency-based medical education, under the leadership of Professor Zafrullah Chaudhary and all my friends, they are sitting here, we felt a challenge during the induction system, the curriculum, the training, the monitoring and evaluation. So this STARS program of the challenge, these challenges, they were defined and then we addressed those challenges. The challenges which we felt are related to the global challenge, which the world felt, and challenges related to our own region, Pakistan. And then the challenges related to the induction. Previously the induction used to be the haphazard, but currently the induction is in January and July. Similarly, the challenges related to the training framework, accreditation. We started the accreditation of the institution and the supervisor. The curriculum, they were revamped by the faculties. Model of training, obviously we adopted the competency-based medical education. Then on-site supervision, that was made, that was strengthened, and e-log system was introduced for a proper monitoring. And the Directorate of Residency program was established under the supervision of Professor Mahmood Ayaz to monitor and to assure the uniformity of the training. Similarly, challenges they were related to the evaluation, examination, shuru mein ek theory paper, then MCQs, what sort of the MCQs, then matching the instructional strategies with curriculum and then with the outcome. Then certification. And the word has got the concept of recertification and revalidation, which we yet have to implement in Pakistan. The word has shifted from process to the outcome based. The reasons of the enhanced healthcare expectation of the society, accountability demands, explosion in the knowledge and technology and information technology bloom. The global challenges which the world has faced and we are facing are the diverse standard of the undergraduate medical education. You are having the undergraduate from the foreign countries like China and Russia, then from the private medical colleges, the public sector medical college, and standard is not the same. Varied clinical practice, disease pattern is different. You will see tuberculosis here, you will see the typhoid perforation here, you will see the 4-stage tumor here, but you won't see these things in various other countries. Similarly, the diverse ethical and cultural and social background, language barrier. Then specific challenges which we face. When the College of Physician Surgeon started in 1962, there were very few people to adopt this postgraduate qualification. But currently, 75 fellowship program, 268 institution, 25,000 plus trainee. Now there is an issue to maintain the quality of the training. And similarly, the specific challenges in Pakistan, they include rapidly expanding training network of PGMI, inadequate preparation and monitoring of the training, issues of the examination and quality assurance. Then we adopted various strategies to cope with these challenges. Different policies and criteria, they were defined in the booklet form. The curriculum book, they were published, and we had the structural visual curricular display chart. Then the minimum standard of induction, they were defined. ELOC system implemented. Faculty development program in the form of 5 or 6 workshops for the faculties. Introduction of the MCPS for medical educationists. Then examination changes in the examination in the form of the on-site assessment, and the various strategies they were adopted. Computer-based examination part 1 intermediate module, and in some of the subject of part 2 examination we shifted the examination to the online, and then quality assurance tools they were adopted. This is the accreditation guideline for the institution and the supervisor. Then the induction system, the part 1 in 11 different disciplines, but now induction is January and July, you know already. And the curricular, the curricular books, they were published by the faculties, and then the structural visual curricular display chart, they were introduced by the faculty, and you have seen these charts, they are present and displayed in the offices of the head of department. Similarly, the training requirement, they were defined. In the past, when I was going through the training process, Professor Mahmood Ayaz and Amer Zama, the requirement was कि 2 और 3 साल का आप सर्टिफिकेट सबमिट करा दें कि आपने ट्रेनिंग ली. लेकिन आहिस्ता आहिस्ता तब्दीलियाँ आती गई. आप ट्रेनिंग में accredited unit and supervisor, approval of supervisor, similarly induction at a specific time, then you are supposed to enter your competency on the e-log, prescribe residency program monitored by Directorate of National Residency Program, prescribe rotations, they are there, mandatory workshop, then something about the research, about the approval of synopsis and the dissertation, and finally these are the requirement before you sit in the examination. In monitoring, we introduce e-log system where the monitoring is prospective 360-degree monitoring, and we expect the student to enter the competency every week, and the residency program monitor those competency after every 3 months. Then faculty development program. You can have the FCPS or equivalent degree. You can be a good clinician. लेकिन आपको अच्छा टीचर बनने के लिए these training courses, they are mandatory. Evaluation workshop, education planning and evaluation, research methodology, assessment of competence and supervisory skill ATLS and ACLS. Then initially we had 240 theory examination, and because of the security reason, college started examination at the same time in Nepal, Saudi Arabia and Pakistan. So we shifted from, I think, the examination to the online, and online examination, they were first started from part 1, then intermediate module, then part 2, and this is the examination going on at all the regional center and simultaneous monitoring at headquarter level. Then quality assurance as far as training is concerned, I've already mentioned the accreditation criteria, supervisor criteria, overarching competencies, single curriculum, competency chart, uniformity, induction, workshop for trainer and supervisor, then examination. Blueprinting of examination, I-Ting banking, uniform examination, multiple assessment tool, guideline for examiner that is there, rubric for scoring, panel of examiner, and then we involve the external examiner to ensure the quality and post hoc analysis. Then foreign exposure I have mentioned, because the principles of the foreign exposure, they are, and the collaborative principles, they include reciprocity, accreditation, exchange of examination, and the collaboration. And basically that program is in Nepal, Saudi Arabia, Birmingham and the Dublin. और जब भी जाते हैं वहाँ के सोफरा से वज़रा से मुलाकात होती है. इस वक्त 462 ट्रेनी दे आर वर्किंग इन द आयरलैंड. दिस इज़ द डिटेल ऑफ दो ट्रेनी. आज भी इंटरव्यू हो रहे हैं बर्मिंघम के साथ. एंड द मोस्ट इम्पॉर्टेंट थिंग इज़ कि हम अपनी शरायत उन्हें बताते हैं. वी एक्रीडेट देयर इंस्टीट्यूशन, वी एक्रीडेट देयर सुपरवाइज़र, वी टेल देम कि ई-लॉग सिस्टम पाकिस्तान का इम्प्लीमेंट होगा इन यूके एंड इन आयरलैंड. और हर 6 महीने ये साल के बाद स्टीयरिंग कमेटी की मीटिंग होती है. लास्ट मीटिंग में these were the president and the representative of the president of Royal Colleges of Ireland, और ई-लॉ की प्रेजेंटेशन दी जा रही है, बतलाया जा रहा है कि आपको सुपरवाइज़र को ये सिस्टम अडॉप्ट करना होगा और हमारे ट्रेनिंग को इस ई-लॉ के ज़रिए मॉनिटर करेंगे. एंड डायरेक्टरेट ऑफ नेशनल रेजिडेंसी प्रोग्राम एंड डायरेक्टरेट ऑफ इंटरनेशनल रिलेशंस विल मॉनिटर दीज थिंग. आयरलैंड के बाद यूके में वी स्टार्टेड द जूनियर फेलोशिप एंड सीनियर फेलोशिप प्रोग्राम. IMM के बाद आप 2 साल के लिए जा सकते हैं. FCPS करने के बाद, फेलोशिप के बाद आप 1 और 2 साल के लिए जा सकते हैं. एंड करेंटली दिस प्रोग्राम इज़ वर्किंग इन यूनिवर्सिटी ऑफ बर्मिंघम, वालसेल, लीड्स, रसल, हल एंड यॉर्कशायर. आजकल जो इंटरव्यू चल रहे हैं, दे आर इन, आई थिंक इन आयरलैंड वी हैव स्टार्टेड दिस प्रोग्राम इन 11 डिसिप्लिन, और इंग्लैंड में तमाम डिसिप्लिन में है. ये 150 प्लस जो ट्रेनिंग काम कर रहे हैं. And similarly, we are trying to train our family physician with the collaboration of Royal Australian College of General Practitioners. Ladies and gentlemen, I conclude, while implementing competency-based medical education, we faced various challenges in training, assessment, monitoring of clinical competency. These challenges were addressed by strengthening the on-site supervision and e-log monitoring. Even though the method used in the developed world for this purpose have a strong evidence base, they have low feasibility for developing country due to high costs involved. Our model, the model of CPSP, of postgraduate medical education, provides an alternative for the developing country, especially if they wish to have the standardized residency program at national level. Thank you very much, and thank you everybody for patient listening.